Hi, this is Mrs. Lewicki, and this is the first of 4 respiratory content PowerPoints for MP4. In class, we will be doing a worksheet on some of the respiratory terminology, also discussing labs and diagnostics, although I'll do a little bit here in this PowerPoint, as well as medications and assessment. So I'm going to start with assessment. And it's important for you to understand where you're going to hear specific breath sounds. Some of those include tracheal, which you'll hear obviously over the trachea, bronchial, which you hear next to the trachea, bronchiovesicular, which is next to the sternum between the scapula, and the rest of the lungs is vesicular. And here's a picture of that. Also, it's important for you to understand the other sounds, the adventitious sounds that you may auscultate. Some of those will be wheezes, which is a continuous sound. You can hear it inspiratory or expiratory. It's caused by a narrowing of the airway. So we primarily will hear wheezes in an asthma attack or that type of situation, and it's caused by some type of a narrowing of that airway. Another continuous sound is rhonchi, and that's a more harsh sound, often caused by like mucus or something in the airways. Fine crackles, which sound like when you take your hair, that's what they sound like, and you rub it between your fingers. That's what crackles sound like, or when you pour milk on Rice Krispies, that sound. Those are often caused by fluid buildup in the alveoli. And then coarse crackles also are in the alveoli, generally speaking, and they're a thicker fluid sound. And both of those are discontinuous sounds. You may also hear stridor. Stridor is when you have some type of an airway obstruction and it's upper airway. It sounds almost like a crowing sound, and I can't make that sound right now, but you get an inflammatory, you get a very loud crowing sound, and it's inspiratory. Rub is like when you're rubbing two balloons together. It's because maybe there's just not enough lubrication between the pleural layers, and you'll hear a rub. A couple of the other diagnostics that we'll talk about, a couple of diagnostics, include bronchoscopy and thoracentesis. As a nurse, it's important for you to know how to prepare the patient for the exam, what to teach the patient, what to expect during the exam, and then how to manage the patient post-procedure. A bronchoscopy is when they insert a flexible fiber optic scope into the airway. They use it for diagnostic purposes. They may collect a biopsy with that, other specimens, so some sputum samples from that, or any assessment changes. And the other thing they'll use that for is pulmonary toileting, or to make sure they're clearing up the secretions if patients have mucus plugs. So they'll suction out mucus plugs, remove any foreign objects, and pulmonary toileting, as I just said. Patient should be NPO for 6 to 12 hours beforehand, and that includes if they're on a tube feeding. That needs to be turned off for 6 to 12 hours beforehand. They need to sign a consent. They should receive conscious sedation, so they'll get a little bit of sedation so that they're easy to arouse and don't require an advanced airway during the procedure. And they're NPO after the procedure until their gag reflex returns. And that's because they'll use a numbing spray in their throat, a lidocaine type, it's called Cetacaine or hurricane spray, or some of the names, and that will cause them to not be able to gag. And so we want to make sure that we keep them NPO. A thoracentesis is when they're going to get a pleural sample from the thoracic space or the pleural space, and they'll take pleural fluid for diagnostics, They may remove fluid because they've got a pleural effusion, which we'll talk about on another PowerPoint. Or they may do it to instill medication if there's an infection that they can't correct. Um, they do have to have an informed consent. The patient will be positioned like so, so leaning in an orthopnic or tripod position over a bedside table, or if they're in bed, because if they're not able to sit up, then they'll be on the sideline, and generally you're pulling their shoulder forward for them to access it. It's usually accessed using ultrasound and then, or visualized using ultrasound, and then they access it with a needle. Um, you want to make sure that you do a post-procedure chest x-ray, and that's to confirm that they didn't cause a pneumothorax with the needle. And you want to observe for signs and symptoms of hypoxia and pneumothorax. The initial sample that comes out might be blood tinged, but after that it should be a serous looking. Other labs that we look at in the respiratory system include CBC, so we're looking for an elevated white blood cell count showing signs of pneumonia is primarily what we're looking at with that. Blood gases, which we'll talk about later. Cultures, so they might collect a sputum sample and they might collect sputum for cytology. Bedside diagnostics include pulse oximetry, for a patient who's ventilated, they'll do an end tidal CO2, and that's part of the monitoring system. Non-invasive radiology would be chest x-ray, which is usually the first thing that we'll do. They may do a CT scan of the chest with or without contrast. They may do an MRI. They may do a VQ scan, although that's not, we don't see that as often. And that's measuring the amount of ventilation to perfusion. And when we look at VQ scans, they're looking at for pulmonary embolism. So we have other things we do for that, mainly the pulmonary angiogram. Or, well, let me backtrack and say, primarily what they will do for, we'll talk about it when we get to pulmonary embolism in another presentation. The primary way we use is a spiral CT scan. The most definitive is a pulmonary angiogram for pulmonary embolism, and they may do a lung biopsy. ABGs, so normal values for ABGs, these are things you should know like for the rest of your nursing life. pH is 7.35 to 7.45. PaO2 is normally 80 to 100, and we'll talk about what it means if it's less than that. PCO2 is 35 to 45, and HCO3 is 22 to 26. Those are the normal values. When we get outside of the normal values is when we look at whether we're in acidosis or alkalosis. So when we look at respiratory problems, a pH of 7.3, less than 7.35 is acidotic, but in the case of respiratory, the high CO2 is acidotic. So the PaCO2, which there should be a P on that slide, is greater than 45, and that's respiratory acidosis. It may be the respiratory system compensating for a metabolic acid alkalosis, or it may be other causes, like if somebody has had sedation or a head injury or something that has caused them to not breathe enough to blow off that CO2. Respiratory alkalosis, my pH is greater than 7.45. My PaCO2 is less than 35. And what I will get is hyperventilation sometimes with that. My patient is blowing off their CO2. It's called respiratory alkalosis, and or it could be the respiratory system compensating for metabolic acidosis. Metabolic acidosis, my pH is less than 7.35, my bicarb is less than 22, and metabolic alkalosis, my pH is greater than 7.45, and my bicarb is greater than 26. We'll talk about metabolic causes when we get into renal and sepsis. I'm just going to briefly talk about compensated and uncompensated. Fully compensated means I have an absolutely normal pH. That's the only thing normal about my blood gas. The opposite value will have compensated for the cause. So if the metabolic system is my problem, my respiratory system will have adjusted, and likewise. Partially compensated, I still have an abnormal pH, but I also have an abnormal opposite value. So whether that's respiratory or metabolic. And uncompensated, I have an abnormal pH. My cause value, CO2 or bicarb, is abnormal, but the opposite value is normal. A couple of other things to talk about is hypoxemia versus hypoxia. Hypoxemia is your PaO2 is below the range of normal for the age group, because as we age, as we get older in the elderly population, they have an accepted level of hypoxemia. Breathing air with low oxygen concentration also can cause that at high altitudes, or if there's respiratory system problems. Hypoxia means I'm not getting enough oxygen to my tissues. It can occur as a result of hypoxemia, and hypoxia, you get a PaO2 of less than 60. Symptoms are, these are all you learned back in MP1 or in your first semester: restlessness, increased heart rate, increased respiratory rate, decreased blood pressure, diaphoresis, weakness, headache, lethargy, and may be demonstrated on their labs. I'm not going to talk about this, but you do have this as a PowerPoint. But this is just when we look at oxygenation and the ventilation part of it. Again, this is just a concept map of separating it out. What are some signs and symptoms and risk factors, labs and diagnostics? What would some nursing diagnoses be, expected outcomes, management, and nursing interventions? So this is my overall plan for a respiratory patient. Airway obstruction. It can be partial or complete. A complete airway obstruction is a medical emergency. Patient would be choking, gagging, coughing, unable to speak. They likely will have stridor. If they started with stridor and they don't have stridor anymore, that means the airway has completely obstructed. You will see all the signs of hypoxemia, including use of accessory muscles, wheezing, restlessness, and tachycardia. The treatment is to get an airway, can be an endotracheal tube. If the airway is too swollen, though, they may have to do a tracheostomy emergently. And here are a couple of artificial airways that we'll talk about. Oral pharyngeal airways, which are right here. These are the oral pharyngeal airways. We usually just abbreviate and call them airways, but OPAs is their official name. They're placed whenever a patient is not able to maintain an open airway. That's usually due to anesthesia or a head injury or something along that line. Nurse may place when needed. If the patient spits it out, they don't need it. You want to make sure that you get the right size. You can see they come in a variety of sizes. You measure from the tip of their ear to their lip, and you insert it like it looks like a hook. So you do hook up, turn it around, and it goes down past the tongue. And you want to have available at the bedside if indicated. So places like the emergency room, the operating room, ICUs, they're at the bedside. On other regular floors, they would be located likely on the code card, but know where yours are located. The other one is a nasal trumpet or a nasal pharyngeal airway. That's this one. You can see it kind of has a pointy end, but it is a soft, flexible tube. It's called a nasal trumpet because what you see out of their nose looks like a trumpet, like the musical instrument, a trumpet. It's usually placed by RT. It will be lubricated, and it's used when the patient is unable to clear their secretions up for pulmonary toileting. You want to, again, use the right size. And it gives a path for suctioning. Other advanced airways, there's 2 videos on here, which I'm going to ask you to watch on your own. Um, so we have endotracheal tube. It's used to, which is this one. It's used to maintain an open airway. You can hook it up to a ventilator, or it can be hooked up to oxygen. It is inserted into the trachea. It's inserted by an RT, respiratory therapist, or by a physician. It's used to remove secretions, provide increased oxygen concentrations, placed by an MD or a respiratory therapist. A lot of hospitals and by paramedics. And a lot of hospitals, they use a gyroscope now to place. Otherwise, it's a blind insertion. Adult sizes have cuffs, and that's what this part is, and that holds it in place. Child sizes usually do not have cuffs. And we'll talk later about what the role of the nurse is when the patient is intubated. Tracheostomy, and these are a variety of trachs, is an opening into the trachea. That's the tracheotomy, and the tracheostomy is the stoma itself. It's used to bypass upper airway obstruction, or if somebody's been on a ventilator and they're going to need long-term ventilation, they'll put a tracheostomy in. Ease of removal of secretions. Always have a spare trach at the bedside for emergencies. It is secured using a neck securement device. You want to make sure they're not changed for the first 24 hours. They will oftentimes put retention sutures in, and the retention sutures are to make sure that the neck muscle stays open. There's different types. There's fenestrated, there's cuffless, there's there's some that don't have intercannulas. The one pictured here has an intercannula, and we'll talk about this in class, and I'll show you some. And you want to change the trach tube. They change it periodically, but the physician does the first change, and after that, then it's a monthly trach tube change.